Hello, everyone, and thank you so much for joining us tonight. Tonight, we're going to be talking about strategies for responsive teaching in substance abuse care. I'm joined tonight by my wonderful colleague, and I'll let Dr. Jamie Woods introduce herself.
Oh, thank you so much, Dr. Terrell. I'm Jamie Woods. A lot of you guys already know me. I'm Associate Professor of Psychiatry here at the University of California, Riverside in their School of Medicine, Department of Psychiatry. It's a great honor to have you guys listen in tonight. I think it's what we're going to talk about. It's going to be very, very helpful for us.
Thank you. And I'm Rosemary Tyrrell. I think most of you know me as well. I'm the Director of the Office of Faculty Development at the UCR School of Medicine. I'm also an Assistant Professor in the Department of Social Medicine, Population and Public Health. And this is a topic that is very near and dear to my heart. So I'm very happy that we're talking about these issues here tonight. And of course, because of CME, we have to make the following disclosures that we have no relevant financial relationships. I have no relevant financial relationships to disclose, but Dr. Wood has disclosed a relevant financial relationship as a speaker for, I don't know how to pronounce that, but I'm guessing it's AbbVie at any division. So
Happy, that's right.
there we go.
Yes.
And I'm an ed person, so I always start with learning objectives. And tonight we hope you should be able to analyze some common misconceptions about inclusive teaching and identify the need for creating equitable and inclusive learning environments to detect some examples of microaggressions, particularly those that crop up frequently in a learning environment, and implicit bias that exists, and apply evidence-based methods to foster an inclusive and supportive learning environment and outline effective approaches to responding to bias and integrating debiasing strategies into teaching practice, time permitting. So I'd like to start us off just with a real quick poll. Just select all the statements and you can just scan that QR code or you can join by web. It's pollev.com and that's Dr. T UCR. So that's what that little acronym is. Or you can actually do text as well. So I'll give you just a second to respond to that. So which ones do you think are true? I treat all students the same, therefore I have an inclusive environment. My classroom is inclusive because my students are demographically diverse. I teach in the STEM field, so discussions of inclusions aren't relevant to my courses. And inclusion is an educational fad. The pendulum will swing back, so why bother? I know I have an inclusive environment because everybody seems happy. And I'm waiting for people to mark which ones they say are true. And since I'm not seeing anyone, I'm guessing that some people feel they aren't true. So a couple of people have said they think that A and B are true. And I'm going to maybe say that this was maybe a bit of an unfair poll because all of these statements are false. And the reason I use them in this workshop isn't because I think you won't recognize that they are, but I've actually heard every single one of these statements made in workshops similar to this one. And again, treating everyone the same is not necessarily an equitable practice because everyone isn't the same. And the students being demographically diverse, that's great, but it doesn't necessarily mean that they're all feeling included and equally feeling a part of the learning environment. And of course, I would argue as to see that it's even more important in fields like STEM fields where they have been traditionally not very open to underrepresented individuals. And this educational fad, speaking to D, it's been around for about 25 to 30 years. I don't think the pendulum is swinging back, despite the current attack on anything related to DEI. It's here to stay. And just because people seem happy doesn't mean they are. Students actually are pretty expert at hiding their displeasure sometimes, especially in environments like a clinical teaching environment where they don't have any anonymity. You know who they are. So, what is inclusive teaching? It's always good to start with a little bit of a definition of what we mean by that. And it's inclusive teaching is a range of explicit practices that consider the diverse needs and backgrounds of all learners to create a learning climate where all learners feel valued and have equal access to learn. So, the two main takeaways here are that it isn't implicit. So just because you feel like you're a fair person or believe in inclusive environments, that automatically means your learning environment is inclusive because these are actual practices that you have to do explicitly. And it's also about learning climate and learning environment where everyone has an equal opportunity to learning. So in other words, inclusive teaching really is just good teaching. And I've got one more little opening activity, and this is a waterfall. And if you've been to these sessions before, you probably experienced it. If you've never done a waterfall before, I ask you to write your answer in the chat, but not hit enter until I count down so that all the answers come in the chat like a waterfall. So, why is creating an inclusive learning environment important? Anything you can think of, there's no wrong answer here. I'll give you a minute to type it in, but don't hit enter quite yet. Okay, hopefully you've had a chance. Oh, we've got somebody in the waiting room. Let me get them in here. All right, here we go. 1, 2, 3, hit enter. Yes, great. It worked. Trying to get my chat box where I can see it. Um, the Yeah, so each learner can learn. It facilitates good learning. It's the right thing to do. I love that. To allow different voices to be heard. It's interesting because Dr. Woods and I were talking about that just before the session. We want all students to have a good experience, to promote participation and active learning, which is also good learning. Like I said, inclusive teaching is really good teaching. So, one of the things to think about is what goes on in the mind of a learner who maybe experiences a microaggression in the learning environment, whether that's from a faculty member or a patient or a peer. Although it usually is that we're primarily talking about faculty impact. So, what goes on inside their head? And this probably doesn't come as much of a surprise to some of you, but this is sort of the thought process that typically goes on. Did what I think happened really just happen? Right? And if it did, was that an intentional slight or was that an unintentional slight? And if it was either, how do I now respond to this? And if I do respond, what will the consequences be? Will I be told that I'm crazy, that I'm being oversensitive? Will the professor isolate me or label me as a troublemaker or think I'm, again, oversensitive? Will it affect my grades? Will I not get honors or high pass because of this incident? And consider for a minute the additional cognitive load that puts on learners who are experiencing these kinds of microaggressions sometimes on a daily basis, as opposed to students who don't have to deal with those kinds of microaggressions. We also know from research that repeated exposure to mistreatment and microaggressions has a very deep impact on learners. It can lead to a depression and trauma, almost like post-traumatic stress. It can lead to suicidal ideation and reduced trust, not just for the instructor who participated in the microaggression, but for the medical school generally and the field of medicine generally. So it can really sort of poison the entire experience, especially if it's having an ongoing impact and it's happening all the time. We also know from other research that, according to Bannister et al., that a positive learning environment helps students succeed, affects their ethical and personal development, and that's a critically important one. So if they're in sort of hostile environment, their own ethics are negatively impacted by that. So we're just sort of feeding this bad example. And they also models a more humanistic approach to medicine, which can lead to better and more patient-centered care. So again, it's not just affecting the learner, it's affecting their entire attitudes, and it may affect their patients as well as they start doing that. So again, I like to focus, we've all had a lot of training in these areas, but I like to focus on things that happen commonly in the learning environment for these workshops. And I have a video, and I'm just realizing that I may not have set up the audio properly. So if you can't hear it, I will not, I will skip over it. It's short and it explains the issue quite well. You may have seen it before, but I need to warn you in advance that there's some mature language in it. So let me know if you can hear this.
Prop 50 threatens what voters built. Voters
And of course, there's an ad.
To create fair election districts. Prop 50 destroys this good work. It's
Sorry about the ad.
On democracy that tears away.
I guess I need to pay for YouTube now to get rid of these ads. It's really distracting.
People who
There we
still
go.
don't think that microaggressions are.
Can you hear it? I can't see you, so let me know if you can hear this. Yes? No? Maybe?
Yes, we can hear it.
Thank you. All right.
Problem?
Oh, you're so well spoken.
Oh, just imagine instead of being a stupid comment, a microaggression is a mosquito bite.
Ugh, it's a compliment.
Mosquito bites and their itch are one of nature's most annoying features. But if you're only bitten every once in a while,
No, where are you really from?
Cleveland?
sure, it's annoying, but it's not that big a deal. The problem is that some people get bitten by mosquitoes a lot more than other people. I mean, a lot more. Whether it's on a date,
Oh, your English is so good.
Excuse me?
going grocery shopping,
You know, everything happens for a reason.
I'm just buying apples.
commuting to work,
So when are you gonna have a baby?
watching TV.
Sorry.
Redskins name, part of our culture and history.
Or just walking down the street with your partner.
Didn't even tell you were gay.
Mosquitoes seem to pop up everywhere.
John, got it,
So
but Batman here too.
And getting bit by mosquitoes every goddamn day,
Touch your hair.
multiple times a day,
Pretty.
Can I touch it? Can I?
is fucking annoying. But it makes you want to go ballistic on those mosquitoes. It seems like a huge overreaction to people who only get bit every once in a while.
It's just a mosquito bite. Who cares? Just another angry black woman.
Of course, beyond just being annoying, some mosquitoes carry truly threatening diseases that can mess up your life for years.
Astrophysics? Maybe you should try this challenging major.
Oh, your dreams.
And other mosquitoes carry strains that can even kill you.
It looked like he was up to trouble, okay? I felt threatened.
So next time you think someone's overreacting, just remember, some people experience mosquito bites all the time.
You're all so exotic. Wow.
And by mosquito bites, we mean microaggressions.
So I think that obviously when we're talking about microaggressions, we're talking about the seemingly minor issues, but the research has shown that the cumulative effect of these is extremely detrimental, as the video points out. And I actually don't like the term microaggressions because it makes it sound like it's a small thing. So it's not about someone being, a female doctor being mistaken for a nurse. It's the continually, like the mosquito bites in the video. It's a continually experiencing this over and over again. I really think that we should call them multi-aggressions instead of microaggressions because that's in fact what they are. So one of the common microaggressions that we see in learning environment is the tendency to focus on them as isolated incidents. And that can sometimes occur out of a really good desire to address those incidents in real time. And that's positive, of course, but if we only look at these things as isolated incidents and focus our whole attention around addressing an individual issue, we can sometimes fail to see them as pervasive in our learning environment, we can risk minimalizing or trivializing the problem because we may be addressing one brief incident or one brief comment. We risk making it seem like it's not a big deal, it's minor. And we might fail to address systemic issues that may be contributing to those individual incidents. And I'm sure we've all seen this in practice. And we always say the student who asks a question in class is really speaking for a lot of other students who were too timid to ask the question. Well, the same thing's true here. The student who reports this is probably speaking for a lot of other students who have experienced this and were not as brave to bring it up. Another common microaggression in the learning environment is misnaming the learner, and I've heard learners complain about this over many, many years. So I had two students come to me, this was right here at UCR, and say, look, there's only two Black women in this cohort, and our professors are continually calling us by each other's names. So again, what does that say? That says, I don't see you as an individual. I just have you in this little box. And according to Van Meer, and I love this quote, to be called by our correct name is to receive recognition, and the experience of being recognized inextricably intertwined with selfhood, identity, and a sense of personal being. When we call one student by another student's name, the underlying message of that is, you're all the same. You're all the same to me. I don't see you as an individual. And of course, that may not be what you think you're saying, but that can be how it's interpreted. Another one, of course, is common in learning environments is repeatedly mispronouncing people's names when they have, especially when they have corrected you, or not bothering to ask them how to pronounce a name that maybe doesn't come easily to your tongue. And this is very common learner complaint. And even though my name is fairly common, people always mispronounce it. So I actually can relate to this quote. I'm not sure I'm saying it right anymore. And the reason that teardrop is on there is because that's how you pronounce my name, Tyrell, Tyr. A lot of people say Tyrell. That's incorrect. So unequal attention is another common microaggression in a learning environment. We know from educational research that some students receive more attention from their professors than others, that professors are more likely to call on men than women when they're asking Socratic questions. They're less likely to use follow-up questions when they do get responses from their female students, and that they're more likely to interrupt women more. This also happens in business meetings, by the way, that's well documented, but again, that's another conversation. They're also more likely to call on white students and give those students more time to think and respond than the students of color that they acknowledge. So the gender issues are true, whether the professor is a man or a woman, identifies as a man or a woman. The racial bias is more likely when the professor is white and the person is not. So that those are kind of separate issues, but fall into that same category of unequal attention from the instructor. The notion that communication styles of the dominant culture are the ideal or they're the norm, and anything outside of that norm is unprofessional or it's rude. If it's negatively affecting patient care, of course, that's a different matter. But we see this a lot in learning environments, and that is pathologizing people's cultural communication styles. So again, examples of this might be, it's really impolite to interrupt people. Okay, I get that. I've heard it my whole life. I'm Italian. In my family, if you don't interrupt, you'd never get heard. I swear, the first 5 years of my relationship with my current husband, they thought he couldn't talk at all because he didn't want to interrupt. So rather than pathologizing that and calling that rude, perhaps it could be seen as passion or enthusiasm. Telling someone they talk too fast or they talk too slow. Are you sure that's a communication issue? Or is that just a cultural difference in the way they communicate? Some learners are often told to speak up more, to speak more loudly, or worse, we've seen there's research on this that Asian students are evaluated more poorly on patient communication skills simply because they might be more soft-spoken. Again, Is that a patient care issue, a bad communication issue, or is that just a cultural difference in the way that person is communicating? And when you pathologize a learner's communication style within the learning environment, you're likely sending a message that says you need to assimilate to the dominant culture, which, of course, in this country, primarily we're talking about, white dominant culture, to that you can't be yourself in this environment, that you have to sort of conform to a different way of being, that we have no room for diversity in this learning environment, and that everyone in this learning environment is expected to think and act alike. Now I'm going to stop sharing my screen and turn the mic over to my colleague, who's going to take it from here.
Okay, are we seeing the presenter mode or the other mode?
The mode for you, the presenter, I guess that's what it's called.
Okay, so let's do this.
We're seeing all the slides.
Okay, well, that's not going to work then. Okay, let's go with this. Can you guys see my slide?
We can see your slide, yes.
Okay, so let's go ahead and see if we can start the slideshow again. There we go. We can see the slide a little bit better now.
Yes, that's now we can see the full slide.
Great. Thank you so much for your patience. So I want to go ahead. Thank you, first of all, Dr. Tyrrell. I really appreciate that. You've done a wonderful job of helping us understand how important inclusive teaching is and how inclusive teaching is good teaching too as well. So what we're going to do right now is we're going to say how are we going to be able to translate that into putting together a curriculum that we're going to use in a hypothetical situation to teach medical students or residents how to screen for substance abuse disorders, and maybe in the LGBTQ plus population. That's something that's going to require both clinical skill and cultural competence too as well. So what I've done is I've went ahead and put together a little PowerPoint presentation that has the 6 steps that I think are going to be important and when the rubber meets the road and when we get ready to put this curriculum together. So the first thing that we want to be able to do is cover the foundational information, the epidemiology. How often is this? Why is this important? And also we want to spend some time teaching our medical students and residents, what are some of the risk factors that we have? Social stigma is something in the LGBTQ plus population that you might not have in another population too as well. And we're coming at this from an unlevel playing field because there is a tremendous amount of mistrust in our providers because the way that they were treated or their family members were treated when they saw our provider too as well. So what we're going to do is we're going to spend a couple of times in this couple of minutes in this hypothetical workshop teaching cultural competence too as well. Learning the terminology is very important. And yes, I know it seems like it's overwhelming. We're going to talk about that in a few minutes, but we can learn the basic terminology that we need to learn so that we can have a greater appreciation of what it's like to be in that community too as well, because a lot of this involves implicit bias too as well. And we're going to talk about that as we go along a little bit further. And then case discussions too as well can be very, very helpful in terms of our hypothetical teaching curriculum too as well. Sooner or later, we're going to have to get ready to ask our patients some tough questions if we're putting this together for substance use disorders in the LGBTQ plus population. So these are some of the screening instruments after we have engaged the patient, after we've established that trust too as well. And I want to spend just a couple of minutes talking about these screening instruments too as well. So maybe we won't get a couple of minutes to talk about that. So not a problem there. So anyway, the audit is a screening instrument for drug use disorders. The CAGE is for alcohol. The DAST is a little bit more involved for alcohol too as well. The ASSIST is a great comprehensive program, and there's also one called CRAFT, CRAFFT, which also talks about how to screen for substance use disorders in adolescents too as well. So screening, brief intervention, and referral to treatment are going to make up the skeleton of what we're going to try to teach attempt to teach our students and residents to as well. Well, how are we going to be able to demonstrate that they've learned this? Well, let's go ahead. We have clinical simulations. We have role-playing exercises that we could do. And these things are going to help build rapport. They're going to help understand non-judgmental inquiry, because in a workshop like this, when you hear somebody else have a microaggression, then it's easier maybe to point out somebody else's than yours yourself too. So you're going to hone your ability to perform this inquiry in a non-judgmental way. And we're going to be able to address patient concerns about discrimination in a culturally sensitive fashion too. I think step number 5 is really important too as well, and that's involve our community. So being able to send our patients, for example, as a transgender individual, to the Transgender Health and Wellness Center in Riverside, California, or True Evolution, or the LGBTQ plus Center of the Inland Empire too as well. So being able to know where to refer our patients to appropriate community members is a very, very important job. It's not just writing prescriptions. And finally, evaluation and reflection too as well. I think the 6th one is really the most important, because that's going to help us reflect back. What was your comfort level when you first started, and what's your comfort level now? And what biases, implicit biases, have you discovered about yourself? The ones that you don't know are the ones that are going to rise up and be problematic for you. And it helps us learn what we still need to learn too as well. How would we objectively evaluate these? OSCEs, of course, too as well. While it's important to talk about these kind of learning objectives, it's another thing to put it into a sample lesson plan too as well. So what I want to do is thank Dr. Tyrrell for her efforts for this next slide right here. And she's put together a sample lesson plan that incorporates all these principles. Want to thank her for doing that. And this sample lesson plan really satisfies these learning objectives to be able to demonstrate the unique risk factors for substance use disorders in our population, and to be able to better demonstrate and use inclusive, validated screening tools, and to communicate effectively and respectfully too with these patients while we're doing the screening, and to be able to identify referral pathways that we talked about in the previous slide, and resources too as well. She has put together a QR code, so if you want to download this or learn more about it, you will have the opportunity just by scanning the QR code. What she's done is put together this in a graphic form right here for a hypothetical 90-minute workshop that we'd have. First 15 minutes studying those epidemiology slides. Why is this important? Why is the risk that much greater? So we definitely want to create the unmet need. The next 20 minutes with a mini workshop. Dr. Tyrrell is going to talk about that when her time comes back around in just a couple of minutes too as well. So we're going to talk about avoiding assumptions and kind of staying away from implicit bias too as well. And then we're going to take the information in our hypothetical workshop and we're going to put it to work there with students working with a standardized patient, or role play too as well. maybe taking a culturally sensitive history screening for substance use disorders in this hypothetical situation, using the SBIRT framework too as well. Then, of course, we want to have a couple of minutes to kind of debrief and to talk about what we learned in that particular situation, both that we've learned that we did wrong, or maybe that other people did wrong, that we can assimilate and we can incorporate into our teaching style. And then a few minutes for wrap up and reflection too as well. So what I want to do at this point in time is kind of turn it over to you guys, Dr. Tyrrell and I, and see, we've got about 4 or 5 minutes. We're making relatively good time at this point, and to see if there are any questions or comments or thing that anyone would like to address at this point in time.
Feel free to unmute or to put your comments or questions in the chat. Either is fine.
I had to work hard to get the PowerPoint presentation up, so I can't see the chat, and I don't want to close it to read the chat because
No,
then I
we
might have
have
problems
we
pulling
have
it back
one
up.
question.
So, Carol, if
There's
you would be kind enough to
yeah.
be, thank you.
We have a question. How generalizable is the LGBTQ approach to other populations?
I would like to take the first shot at that.
Mhm.
You know, we experience microaggressions just like other populations experience microaggressions too as well. So there are certain microaggressions that are going to be specific for me as a transgender person, just like there are going to be certain microaggressions that might be directed towards another queer population too as well. But the ability to create this culturally sensitive environment is important, whether you're working with maybe a queer population, but also maybe if you're working with a Latinx population too as well. They have different microaggressions, but the same framework, I think, applies in both cases.
I agree. I think that if you look at your lesson plan, it actually does provide a very clear framework that I think could easily be adapted for any population that you are working with, whether you were working with maybe an undocumented population or a specific ethnic group, or people of a certain age. There's all sorts of different demographic groups that this could easily apply to. That's a great question. Thank you for that.
Absolutely. It is.
If I can add, I also think it has to do a little bit with sort of framework we've been talking about, cultural humility, right? Where
Mhm.
it's good to know a bit about what that particular community might experience in terms of microaggressions or bias, and worse, and have an understanding in the background, but also having that cultural humility and more inquisitive, how can you understand that patient in front of you without stereotyping, but having some context of curiosity about their context.
Absolutely. And if you don't know what to do, just ask them, teach me. And our patients are delighted. They don't want you to try to pretend that you know something that you don't, or maybe make a microaggression. So if you don't really know about a particular population, it's absolutely okay. And they feel when we ask those questions, that shows our patients that we care enough about them to be able to want to do it right too as well. And that's when patients feel included. Wow, okay, Dr. Woods, wants to know what it's like for me too as well. And when that happens, patients feel heard. And the most important thing, I think, in a doctor-patient relationship is for the patient to walk away feeling heard. All right. Any other questions? Shall we move forward? I think that sounds good too as well. So we've talked about a sample lesson plan. We've talked about inclusion being good teaching too as well. We talked about microaggressions and how they have this cumulative effect too as well. So when we get ready to put this together, well, the first part will be a didactic presentation. So what does a PowerPoint presentation look like in this particular situation? Well, we can design it any way that we want to do it. But I think the same principles of epidemiology, the didactic presentation, this is maybe what it would look like in a sample PowerPoint slide right there. We might want to talk about why is this important? You know, why is this a need right here? We're going to find out when we look into this a little bit more closely, looking at the data of the patients that identify specifically as LGBTQ plus. 50% of these adults made the DSM-5 diagnosis for a mental illness. And 42% of that 50% had a serious mental illness too as well. And about a third of patients who identified as queer had met criteria for a substance use disorder. And of those adults, 60% struggled with illicit drugs, about 63% struggled with alcohol, and about a quarter of them struggle with both. So what can we say? We can say about a quarter of our LGBTQ plus patients are coming in with both a substance use disorder and a concurrent mental illness too as well. So this creates a tremendous opportunity for us to make a significant impact if we do it right. Well, what kind of drugs are we talking about here? Well, certainly, while they're great generalizations too as well, there are some specific instances, and we've got, 10 other PowerPoint slides to talk about each one. But whether it's marijuana, whether it's psychotherapeutic drugs that we're talking about, whether it's sleeping pills or something like that, whether they're hallucinogens, ketamine, psilocybin, MDMA, or Molly or ecstasy, whether it's cocaine more in heterosexual men, methamphetamine more in gay men. So there are some differences between these two when you break them apart. Inhalants surprisingly was higher than I thought it would be in this population, as well as opiates too as well. So there's very much an unmet need. And I think the first part of the presentation is to help us understand why this matters. And so now we understand that first bullet point, there are higher rates in LGBTQ plus individuals. Well, what are some of the reasons why that's the case? What can be going on? Certainly stigma still in California, in Palm Springs, stigma still exists. There's minority stress. There's intersecting identities too as well. So, you can be trans and Black. And Black transgender women of color, by the way, 5 out of 6 homicides are Black transgender women of color too as well. There's the isolation that goes along with being in the closet, not being able to be fully out. And with all that going on, a lot of these patients are going to present with anxiety disorders, depressive disorders, and either recent or far away or both trauma too as well. And we can play a very critical role in being able to reduce the further harm that's going on too as well. So whether it is stigma, minority stress, isolation, or treating their comorbid anxiety disorders, it's within the capability of everybody attending this lecture to be able to significantly impact their mental health as well as their physical health too as well. So, how can we do this? How are we going to be able to incorporate that when we sit down across the table from our patients to be able to ask about very difficult topics, very sensitive topics in a culturally sensitive way? Well, this is where we need to develop some inclusive treatment strategies. So at this point in time, I'd like to popcorn back over to Dr. Tyrrell, who is going to talk about some inclusive teaching strategies. So go ahead.
Thank you. Thank you so much, Dr. Woods. That was excellent. And I think that it really dovetails perfectly with what I want to talk about next, which is the teaching strategies related to teaching students about some of the issues that Dr. Woods just shared with us. And before I do that, I want to just briefly touch on the concept of intention versus impact. So intent is not completely irrelevant. I've been in many workshops where I said, doesn't matter what your intention was. Of course it matters. That's why we have different laws for murder and manslaughter, because we know inherently that intent does make a difference. However, just because the intent wasn't to do harm doesn't mean that harm wasn't done. So the problem here when we're talking about inclusive teaching is that a lot of people use this concept of intent to try to shift the responsibility from themselves to the person on the receiving end of the bias or microaggression. Since it wasn't their intention to cause offense, then the problem must be that the other person is overly sensitive or reading something into the remark that wasn't really there. But if the impact of our actions is furthering oppression, then that's really all that matters, whether we intended that or not. What we want to do is shift the focus from what was intended to how the incident impacted the individual who was on the receiving end. So also our tendency, as I mentioned before, to focus on isolated incidents can distract from critically analyzing the pervasiveness of bias in our larger systems of education. And again, this was from the AAMC Forum on Inclusion and Diversity. A lot of the data that I'm going to use today are from that study. So, some of the terms that you may have heard colleagues use when talking about students, right? If it's this face to face, I usually toss a ball around the room and ask people, well, I know you would never use these terms, but what are some that you may have heard other people use? Well, you may have heard some people refer to our students as entitled, as spoiled, as distracted by their technology, can't get their attention, as needy, they want a trophy just for showing up. They want constant praise and affirmation, or that they're lazy. They don't want to work hard for what they get. They want everything just handed to them. Now, I just want you to take one moment to think about how offensive these labels would be if we were applying them to an ethnic group. People would be outraged if you said these kind of things. So what makes it okay to apply them to any group, such as an age cohort? It isn't okay. So you need to really be careful when you start putting labels on groups of people. An individual might be lazy and you might have good reason for saying that they are. But to say that all students of a certain generation are these things is basically stereotyping. I wanted to explain that the images that I'm using here come from two different sources. One is the Harvard I2M Harvard project, where the students are holding the signs of things that were actually said to them. And the second one with people's painted on their backs is from a project called I'm Tired, where people talked about how these kinds of things were impacting them. So one of the inclusive strategies to establish ground rules in your learning environment, and that doesn't have to take a lot of time. So ground rules basically hold students accountable for any behavior within the learning environment. They can prevent issues of incivility because you make it clear that that will not be tolerated in your clinical environment, classroom, or lab environment. Students understand clearly that the expectations exist for civility and inclusivity, and they can hold each other accountable for that as well in a variety of learning scenarios. So it creates a more safe environment. There's, a research that shows that just having a statement on your syllabus, and I know that's not as applicable in a clinical environment, but I'm going to make this point that just having a statement on your syllabus saying that you respect, inclusion and diversity makes underrepresented students feel more comfortable in your learning environment. There's research that backs that up. So imagine how much more comfortable they'd be if you actually take time at the beginning of your rotation or your session to just quickly establish norms around this and ground rules. I was at another workshop where someone said, well, if we're overly sensitive to people's cultural identity in the learning environment, we aren't preparing them for patients who might be rude or bigoted or insensitive. And, I thought a lot about that comment after the workshop. And I guess after giving it some thought, I would argue that people who are from underrepresented groups don't need to be taught what it's like to face bigotry. They often have lived that their entire lives. What we're trying to create at the School of Medicine is to create a learning environment where all students have the equal opportunity to learn, not a place where some students are asked to carry that heavier cognitive burden just because of who they are. So that would be my answer to that question. So again, another strategy is just to use inclusive language. So use terms of equal weight when you're referring to parallel groups. So if you're saying men and women, instead of men and ladies? Do you always, when you're using examples, do you always use the male gender first, or do you always tack on or other as if it was some, additional thing, or are you really using inclusive language when you're talking about gender identity? When you give examples, are you inherently uh, gendering those examples? A doctor is always he, a nurse is always she. I was in a class where the instructor was an expert on ethnic diversity, but whenever she gave an example, she did this. And in her examples, the males were always in leadership roles, and the females were always in lesser roles. So she would say things like, whether you're, the some guy who's the principal of the school or the cleaning lady, and she did this all the time. And I thought, well, first of all, who uses the term cleaning lady anymore? But when I pointed it out to her, she didn't apologize. She didn't acknowledge it was a problem. So just because you may be sensitive to diversity in one area doesn't necessarily mean you might not have a blind spot in other areas. And I have other examples, but I don't have time to give them all. And again, avoiding assumptions, framing heterosexuality as the norm in all your examples. And I had students say, well, the only time my instructor ever brings up, the LGBTQ population is when they're talking about AIDS. I mean, talk about a stereotype. One of the favorite things that I often quote now that Dr. Wood said in a workshop or in a session meeting that we were having on LGBTQ plus curriculum was, gay people have heart attacks too. And I just remember that so clearly, her saying that. Uh, so again, refrain from remarks that make assumptions about students they may not be true. So that might include something like a socioeconomic background. I can't tell you the number of times I've sat in classes observing teaching and heard instructors go on and on about how important it is to travel and, all these great experiences that you can have in Europe and overseas without any seemingly understanding that there may be students in the room for whom that is not a possibility. Family backgrounds and relationships. And now, at the risk of oversharing, I'm going to give you a personal example of this. So when I started my doctoral program at UCLA, the first major assignment was called The Leadership Story. And this was supposed to be about all the influences that led you to your current leadership style. Okay, that sounds fine. So I intentionally sort of skimmed over my childhood and I was called out. So in one of the drafts, the professor said, you have to give many more details about your childhood. So not only did we have to write this paper, but we had to give an oral report on this. So I'm sitting in the room and I'm listening to one after another of these other students sing the praises of their parents and how wonderful their childhood was. And I had to start my report by saying, my childhood was a Gothic novel. So I was exposed. And sharing that level of detail, let's just say about my difficult childhood, really, it's kind of more of a third date kind of thing. So assuming that all students have positive stories to tell about their childhood influences is an assumption you cannot make in an inclusive learning environment. Some people have very different kinds of stories that they are now feeling forced to share. Whenever I ask students to do a reflective assignment that they're going to have to share, I always say, you're going to be asked to share. So please only share things at whatever level you are comfortable of sharing. Because sometimes people are sort of being asked to out themselves about issues that they may not really feel comfortable sharing. And again, don't make assumptions about a shared cultural literacy. Age is a big factor in this. I've seen professors cling to cultural historical references that are, so far outside of our students' experience I say, like liking something to Vietnam War protests, you might as well be talking about the War of 1812 as far as our students are concerned. Again, any assumptions about relationship status or sexual identity, just all of that. Thinking about what am I doing in my case studies, in my test questions, in my examples, in whether it's didactic or even just using clinical, question and answer periods, Socratic methods. How am I incorporating inclusivity in that? So when you ask prompt questions or you're trying to jumpstart a discussion, are you ensuring that everyone is equally comfortable joining in? Are you just tossing the question to everyone? If you do that, how are you ensuring that you're actually including everyone? There may be students who always volunteer and students who never want to volunteer. Do you respond immediately after the first learner answers your question? You may want to think about that. You may want to I call it the rule of three, where you take three answers before you respond. And again, all of that, maybe there are some students are a little more soft-spoken, would prefer, responding first in a small group before they respond to the big group. Are there lots of different strategies that you can use for ensuring that everyone's voice is heard within the learning environment? And Dr. Woods is going to talk a lot more about terminology. Obviously, it's a very important topic, but I'll let her address that more. Also, another strategy is, are you assessing how you're doing in this area? And I've heard someone, say in a workshop, I know there aren't any issues like this. And one person said in a workshop, well, I know all my students are Christians. And I said, okay, how do we know this? And they couldn't answer that question. I said, well, maybe there are people in your group, in your learning environment who are not Christians. It's probably a good likelihood that there are, maybe there's a few Jews, Muslims, atheists, or Hindus in your group. And they just don't want to say anything because you've clearly made Christianity the norm within your learning environment. So they don't want to speak out. Invite them to write you a note, either signed or unsigned, if they have issues that you want to address. So another way is saying, asking a question like, in what ways, if any, do these issues affect your ability to interact within my learning environment? And sometimes that's better done anonymously. So again, if learners are reluctant to speak out, you can model instigating a difficult conversation. Here's what I heard. Make it clear that you value comments and input. Don't let inappropriate comments stand. Let your learners immediately know that racist, sexist, or other discriminatory remarks will not be tolerated. Learners need to feel empowered to voice their objections. So step in if there seems to be something happening. I observed this once where I was observing teaching in a room, and they were in groups, and one group was all men, one woman in the group. And the whole assignment was they were crashed in the desert. It's called the Desert Survival Game. And you're left with all these items, and you have to just rank the order of priority. How important are these items to your survival? And the woman said, I think the mirror might be important. And one of the men in the group said, why? You want to check your makeup? The instructor said nothing. The student never said another word during the activity, and they let that go. And it probably won't surprise you to find out that the mirror is actually the number one most important item on the list because of its ability to signal for help. And it's like that instructor should have stepped in that moment. So, the only time you don't want to step in is if you think it's going to do more damage to the person, that was offended by calling attention to it. But you have to use your own professional judgment there. So I tend to lean on the side of if it was said in public, then it needs to be addressed in public. Again, with that exception that if the victim of the remark will be more impacted by your making an issue out of it, then you might want to have that conversation privately. And now I'm going to stop again and pass the baton back to my colleague, Dr. Woods.
Thank you, Dr. Tyrrell. go ahead. Great. Thank you so much, Dr. Terrell. I really appreciate that too as well. So let's put the rubber on the road now that we understand the importance of this. How do we go about doing it, and how do we go about educating our students and residents how to do this IRL in real life too as well? How do we engage the LGBTQ plus patient? Well, in researching this PowerPoint presentation, I came across a website that was actually put out by the American Addiction Association, and it is a free webinar series. You may have to pay for it if you want to get CME credits for anybody out there that wants to do it, but this is 8 90-minute pre-recorded training sessions on cultural humility. And both Dr. Terrell and I agree that this is tremendously valuable. It's a tremendous learning opportunity. They do a really, really good job here. They look at social class bias, critical issues in patient care too as well. They have a whole webinar on working with our Latinx community too as well. In the Inland Empire, that is critically important to be able to do that. They have a webinar on respecting differences in diversity and also social responsibility, particularly in the addiction profession, because that's why they were doing it, but this is applicable to all of us too as well. So if you scan on the QR code, again, thank you, Dr. Terrell, for providing this link to as well, then you'll have the opportunity again to learn more about it. So learning cultural humility, of course, is going to be very important. And if you feel like this is something that you need or want to learn more about, this certainly provides that opportunity. So let's get down to how comfortable are you talking about your sexuality? These are some screening questions that, we're going to go ahead and get to right now in our next slide. So how comfortable is the patient in terms of expressing their sexual feelings, sexuality, or gender identity? And what stage are they in the coming out process? And we certainly don't want to out any of our patients in front of anybody else. And, what are the consequences? Have they tried to come out before, or have they suffered, problems with that? And by the way, what is their support group too as well? Don't necessarily assume that they have a very large support group too. A lot of our queer patients live in very, very small communities. And what is their relationship like with their family too as well? If you're 21 or 22 years old, yes, you're an adult. But if you come out, guess what? Your dad, who's an evangelical preacher, who is paying for your tuition, can drop the sword of Damocles or something like that. They can put the hammer down on you. So you have to understand, what are the consequences of being queer in terms of their relationship with their family too as well. We have to ask them sometimes as far as transgender people, 10% of us are asexual. So this is sexual risk factors questions are not something. So you have to tailor it for each individual group too as well. But if the patient does have sexual risk factors, then these are some particular questions that are very, very important in assessing our patients too as well. Are you having sex? How many sexual partners have you had in the past year? Because if you've had sex with 10 people and they've had sex with 10 other people, you've essentially had sex with 100 people. And a lot of times our patients really don't understand that. Who you were having sex with, and what parts of your anatomy were you using for sex? If you were having unprotected anal sex, then your risk for sexually transmitted infections, including HIV and hepatitis, goes through the roof too. How do you protect yourself? Do you use condoms? Are you on PrEP? Are you on PEP too as well? Very important to understand these terminology, these terms, because if our patients have to end up explaining to us, what is going on, then they're not really going to have that trust. So our ability to be able to talk on their level is very, very important. So you may want to are you taking Truvada? It's important for us to know what Truvada is. Truvada is a medication, when taken once a day, will prevent our patients who are having unprotected sex from getting HIV. That's a tremendous advancement. But are you on PEP? it's important for us to understand that all Truvada does is prevent us from getting HIV. It doesn't prevent us from getting syphilis or non-gonococcal urethritis or NGU or any other bacterial infections too as well. But we have a pill that we can take within 48 hours that can really cut down the risk of those types of infections too as well. What's your past history of having sexually transmitted infections? This is an important one too as well. When were you last tested? Very, very important. And has your partner been tested? What's their infection history too as well? The last two bullet points, I do want to take a second and talk about these two as well, because these are critically important to our LGBTQ plus community. Do you use alcohol or meth when you have sex? Methamphetamine usage among gay men is incredibly high, believe it or not. And 1/3 of all new cases of HIV involve methamphetamine too as well. So very, very, very important question to ask there. And finally, especially for the LGBTQ plus population, for the transgender population, 13% of us at any given point in time are couch surfing. We're homeless. We're living out of our cars. One of my friends, she's a transgender woman of color. She told me that she was freezing to death one night. She was homeless. She slept on top of the porta potty because it kept her warm, because the compost, the decomposition generated heat too as well. So the last bullet point, do you exchange sex for money, drugs, or a place to stay? It's a valid question. It's an important question to ask. But to be able to do that in a culturally sensitive way, that's really the critical thing that we're talking about right now. Have you had legal problems? Have you been arrested? I was sentenced 4 months in jail for practicing gender-affirming hormone therapy in the state of Tennessee. Have you ever been assaulted? I've been unconscious before I hit the pavement. Have you been in treatment before? Substance abuse treatment. What was that like for you when you went into it? Well, what did you learn from it? What did you learn that was bad about it? What can you do? And you're not that person that went through rehab that last time. You're a different person now. What strategies have you developed too as well? So again, what are the social context of where you use these drugs? You can get drugged in a bar. Whether it's a straight bar or a gay bar. So very important for our girls and our patients, LGBTQ plus patients, to watch your drink too as well. So again, what is the social context that we're looking at here? Wow, the terminology can seem overwhelming. I mean, gender dysphoria, gender expression, gender fluid, gender identity, gender nonforming, gender queer, gender transition. I mean, there's just no way in the world that I can make sense of this. Dr. Tyrrell has also put together a QR code too as well that can help us understand the different types of terminologies. What I want to do is break it down for you. If you don't know anything, you don't have to learn all that slide. But this is really critically important if you want to work with us too as well, because everybody has 5 identities. Most people don't realize heterosexual cisgender people, they live a very heteronormative lifestyle. They never question these identities because everything lines up. But for a significant percentage of us, we have intersecting identities too. So I want to spend a couple of seconds. I know we want to get done by 7:30. This is an important slide. And I think if we take nothing away other than this is important. The first identity that I have is my gender identity. My gender identity is not formed down there. It's not formed here. It's formed up here. Regardless of how many surgeries I have or haven't had, or hormones that I have or haven't had, if I identify as transgender, I am a transgender individual. I am no more transgender than somebody else who's not had any of these things. Gender identity starts up here. So you can be transgender, you can be gender non-conforming, you can be non-binary too as well. This is really a critical thing, because if you're working with young people and if you're teaching students and residents too as well, 1/3 of all Gen Zs, and those are our students and our medical students and our residents. Well, first of all, 1 out of 20 of us identify as a gender other than the one we were assigned at birth, and 20% of us in that age group are something other than straight. That's 1 out of 5. So again, very important to be able to have these types of conversations and understand the basics of the terminology that we're talking about right now. 1/3, by the way, of Gen Zs who identify as something other than the gender they were assigned as birth have thrown the gender binary away entirely. 2/3 of those kids are non-binary. They recognize that at the end of the day, it's performative, whether it's masculinity or it's femininity. At the end of the day, these are social constructs. Your sex is not a social construct, but your gender identity is very much a social construct. And these kids have just thrown it away. They don't want to perform one way or the other. They just want to be themselves. So the other identity that we have is how we express our gender too as well. So even I grew up as not male in the 60s. The word transgender didn't exist, but the only option that I had was really to express male. So for the first 63 years of my life, I expressed male. I transitioned 7 years ago. I came out. So now I express female. So it's how do you express your gender too as well. If you're a non-binary person, you may present with a beard and stilettos too as well. So again, it's how do you express it? But the most undeniable thing is our biological sex. And regardless of what the current administration has to say about it, there are about 1.5 million people that are not male or female. And that was not a choice for them. They're intersex too as well. So even your sexuality, even your biological sex exists on a spectrum too. I was assigned male at birth. Well, if you're a transgender woman, then you must be attracted to blah, blah, blah. That sentence holds no more truth to me as a transgender girl as it would if I were a cis girl. Oh, you're a cis girl, so you must be attracted to men. No, well, guess what? I might be a lesbian. So you can't make that assumptions. Dr. Tira was talking about making assumptions previously too as well. Oh, you're a transgender girl. You must be attracted to men. No, only 1/4 of us identify as purely heterosexual. So only 1/4 of trans girls would be solely attracted to just men. 50% of us really don't care what's below. And another 1/4 of us are lesbians. If I were a trans woman, I would be a trans then. So you can't predict my sexual preference as a trans person any more than you could predict my sexual preference as a cis person. And finally, who can you fall in love with too as well? So I'm pan-romantic. I've fallen in love with many cats in my lifetimes too as well. But that's a kind of a humorous example of the different identities that we have. So if you can kind of get a general framework right here, then you have gone a long way into helping understand who we are as people. It's very important to be able to engage us, and it's not just us, it's our front office staff too as well. And I think we have a slide about that too as well. The single most important thing that you can do for me as a trans person is just simply ask my pronouns, because that demonstrates so many positive things. It demonstrates that you care enough to get it right. Okay. And that's very important because that, again, established that level of trust that we have that's so important for good therapeutic outcome too as well. And it's not just he, him, his, or she, her, hers too as well. We're talking about a growing number. 1/3 of us are now binary. So don't be surprised when you're going to have to get a little bit more familiar with they, them pronouns too as well. And I don't care if you're a boomer, guess what? You can do it. It's okay. You can get comfortable with they, them pronouns too as well. It gets easier as you do. But let's say you have somebody that identifies more as female, but will accept a non-binary kind of pronoun. I'm she, they. Another person might be he, they too as well. It never hurts. You never are at a disadvantage if you ask us our pronouns. It shows that you care. But again, there's front office staff too, because if I experience a microaggression, it really doesn't make any difference where it's coming from. It doesn't make any difference coming from the doctor or the front office staff. It's going to sting just as hard. It's going to be that wasp sting or that bee sting. It doesn't make any difference who stung me, as Dr. Terrell was talking about. It's the cumulative effect too as well. So avoid gender specific markers. Can I help you, sir? If you don't know, teach your front office staff. Just how can I help you today? You don't have to actually stick a gender onto that particular person. And if you're unsure about pronouns, the previous slide just talked about, ask about them. That's absolutely okay. It creates an environment of trust too as well. And if you're coming in with your significant other, don't assume, oh, are you coming in? Oh, can I get your husband something to drink? Well, that person might identify as male. So don't assume the gender of your partner, use the term partner instead, any more than you would assume your own gender too as well. And finally, if I come in and my chosen name is Dominique Woods, I might not have $256 to carry down to the clubhouse to be able to change my legal name from Jamie Woods to Dominique Woods too as well. So if I come in and I say, hey, I'm Dominique Woods and I'm checking in for my appointment, we go back, we look for Dominique Woods, don't come out, teach your front office staff not to come out and say, well, what's your real name, hon? Teach them to be a little bit more culturally sensitive and, express a little bit more cultural humility. Could your name be under another name? We file them by, our legal names right now. So again, teaching the front office staff is very, very important too as well. Screening tools. When we get around to it, we're going to have to talk about screening tools. So how do we do it too as well? Well, we've got Cage Aid that is specific for alcohol. Have you ever experienced consequences, felt like you had to cut down? Have other people annoyed you? Or have you ever felt guilty about your drinking? Or do you need a drink to get going in the morning too as well? If you want to have a more specific test, the audit is what we talked about too as well. This is actually the DAST that you see in front of you right now. That's more specific for the drug abuse screening test that we have right there. This is CRAFT right here. Thank you, Dr. Fortuna, for your contribution here too as well. This is a screening instrument, not being a child and adolescent psychiatrist, that is tailored more towards an adolescent environment, more culturally sensitive, using the words that generation identifies with a little bit more. And the ASSIST is a very good instrument that identifies so many different areas, and they break it down for different drugs too as well. And it uses the SBIRT kind of terminology, that framework. Screening, using validated tools, brief intervention. You can go a long way by just establishing trust too as well. Use motivational interviewing and then referral and treatment to resources. So you don't want to have to be in a position to look up these referral sources. However, if you do spend the time doing it, you're showing your patient that you care enough to do it too as well. But if you know who in the community is to give a trans person a little bit of direction on who's going to do their nails in a culturally sensitive way, these referrals can go a long way too as well. So know your affirming resources. In a hypothetical kind of PowerPoint presentation, now we're going to get to the point where we do case studies. Dr. Tier had talked about that earlier too as well. Our hypothetical case study right now, let's look at, for example, Jordan, 24-year-old transgender man, using he, him, because he self-identified using he, him pronouns. And he's coming in with fatigue and frequent headaches. He recently started testosterone therapy from an outside provider. And when asked non-judgmental, yeah, he uses alcohol, and, there are weekends, where he uses alcohol for stress, and there are weekends when he goes out partying, where, he wants to stay up. It's a rave too as well. And when you start to ask more about it, maybe he's really hesitant because of prior microaggressions that he might have experienced before in the past. So making those referral sources are very, very important. Because what we're doing now is we're identifying several issues right here. Here at UCR Health, we can accommodate a lot of these things too as well, because maybe Jordan's going to need some Truvada too as well. Maybe he is using his front hole. Maybe he is going to need some estrace vaginal cream. for that because of the atrophy too as well. Our family practice doctors here, our internists here can go ahead and do the important things about getting Jordan on PrEP and PEP and getting him the appropriate things to treat other presenting symptoms with. In psychiatry, we're available at UCR to treat the depressive symptoms that these patients would present with, the substance use disorders, the anxiety disorders. We all are anxious right now, given the state of what's going on. I can do gender affirming hormone therapy for the transgender and gender expansive individuals too as well. If Jordan is a transgender man and he's not had his TAH-BSO, he's not had his hysterectomy, he still needs to get pap smears too as well. And to be able to get misgendered in the stirrups, if you're a trans guy, that's a macro aggression too as well. So to be able to have these kinds of services available in a culturally humble environment too as well will go a long way too as well. If you don't know, if you want to know more about it, we've got a website for you here too as well. Not only the original website that you talked about with Cultural Humility, but the SAMHSA website too as well. And know who is in your community that can provide these types of services. If I have a trans patient, they're going to need a transgender navigator. I need to be able to tell them, guess what? Trans Tuesdays, every third Tuesday at Transgender Health and Wellness Center, they have a transgender navigate that can help you navigate this complex environment too as well. So want to go ahead then because it's not only one thing to recognize our explicit bias, it's another thing to see other people. What if you notice other people that are exhibiting microaggressions? How do you respond to that? Do you stay quiet? Are you afraid that you really don't want to exacerbate a situation? And Dr. Tyrrell has some finishing slides right here that I think are very important. And what do you do when you see somebody else? Just like it's important to be anti-racist and to call people out for their racist comments, it's very important for us to be able to recognize and be able to intervene in a culturally sensitive way so that we don't keep these microaggressions from happening. So I want to pass it right back over to you.
Great. Thank you so much. I really, we're almost out of time, but so I just have a couple more quick slides that I want to touch base on that I think are pretty important. The, responding to bias within the learning environment is your responsibility as the educator in the environment. So, faculty, there was a study that showed that faculty who role model discriminatory behavior or biased behavior was associated with increasing implicit bias among medical students and residents. So having heard negative comments from attendings or other residents, was a significant predictor of increased bias within those populations. So, we're seeing that not just role modeling, but what do you do if you witness a bias in the environment? What do you do? And it's never easy. It's always challenging. It's uncomfortable. Most people don't like to confront difficult issues, but it's our responsibility as educators to do so. So I'm going to skip ahead a little here because we're running short on time. But there are just a few basic strategies, and I have more that I'm happy to make the slides available for the ones we didn't get to. But one is just simply stopping it in its tracks, interrupting the person before they can do more damage, and providing a statement that supports an inclusive learning environment. So I'm going to stop you right there. This doesn't feel like it's appropriate where this conversation is going. Let's pause. Let's keep that from happening. I just need to interrupt. This doesn't align with our values and the kind of culture we're trying to build here. Another is arousing dissonance with the individual themselves. So pointing out dissonance between, inconsistency between their stated values and belief and what they maybe just said. I'm really surprised to hear you say that. Or that doesn't sound like the supportive colleague that I've been used to working with. What's going on here? Really, again, bringing that up. Yeah, I guess maybe that was a terrible thing for me to say. I don't know what I was thinking. Expressing curiosity without judgment. This gets the speaker to reflect on what they did. they may come to the conclusion themselves that it wasn't the right thing. I wasn't expecting that. Can you tell me a little bit more about what you're trying to say here? I'm not sure I can follow what you're saying. Could you, how are you connecting that to what we're saying here? Again, they may come to that themselves, and then there's just flat out disagreeing. I don't think that's true. That hasn't been my experience when dealing with that population. I don't see that. I just disagree flat out with what you're saying. It's okay. A lot of people find it difficult to call out these kinds of behaviors in the moment. They kind of sometimes will think of like 100 things that they should have said on the drive home, but by then it's too late. So it's a good idea to have a little bit of a script ready so that you can jump in the moment even when you're uncomfortable. So saying, again, you put this in your own words, but something like this, what you just said made me really uncomfortable. You can express it emotionally. Although maybe you didn't mean it this way, but what you said could easily be interpreted as whatever the issue was. And obviously, we want to use our learning environments to turn those difficult, awkward moments into teaching opportunities. So asking the students to stop and reflect critically on whatever assumptions that they may be making and basing those behaviors or comments on. Giving them adequate time and space to name and discuss the anxiety in the room, if it's appropriate. I know in a clinical environment, you don't always have time to sit down and hold hands and have a nice long conversation. So we recognize that. But when it's possible to have those conversations, it can be very beneficial. Focus on the issue. Focus on whatever was said or done, not judging the individual, but just what was done and the impact it may have had on others. That's the key. Don't try to attribute any motives or intent, behind that. Just focus again on the comment, the behavior, the attitude that's being expressed, and acknowledge what it is, the effect that it has on others. And I just have one more slide. And I'm going to slightly contradict something Dr. Woods said, not really, because I think what you said about if you're not sure, asking someone about their pronouns, how to pronounce their name correctly, asking issues related to those issues, it does show caring. But sometimes it's important to educate yourself on these topics. So some people get tired of being the ones that have to educate people outside of their group on issues. And I was in a workshop once where someone expressed this. They said, it's not my job to teach you about racism. And another person said, well, then how can I learn? Now, I was in the audience, so I didn't have the opportunity to say this, but I wanted to say, yeah, it's really too bad there aren't any books, articles, videos, websites, organizations, or other materials out there that might help you learn a little bit about this topic. So it is our responsibility to educate ourselves, and there are just plenty of resources available. The reason that I made that QR code on those free webinars was because I thought they were really, really amazing that resource to have all that available for nothing. It's really an opportunity to learn and grow in an area. So it doesn't always mean, silence doesn't always mean, sometimes, yes, and I'm okay with what you said. Sometimes it just means I'm really tired of explaining to people who don't really care or even want to try to understand. Now, I know our time is up and we want to leave a little bit of time for questions. So this is what we talked about. I just want to take a couple minutes to talk about what we've got coming up. And in our next session, we're going to talk about navigating tough, difficult issues around substance abuse. We also have a project management workshop that's intended for our fellows and early career professionals that everyone is welcome to attend, coming up on the 9th. And on the 23rd, we've got a teaching observation training for members of the team. And those are people who have graduated from the Teaching Excellence Academy. And if you are not a member of the team and you're interested in being one, please do reach out because the Teaching Excellence Academy is our flagship program. It's a competitive program that you have to be nominated. You have to be nominated, you have to apply for it, and you have to be selected by a committee. But it's been a highly successful program for people who really are passionate about learning and teaching and becoming, exemplars. And often it's people who are advanced who, because it's a learning community, so everyone there in the room is an expert and we're all learning from each other. Uh, we also ask that you please take a few minutes to respond to a survey on tonight's session. We really do care about what you think. It helps us with the program, the SAMHSA program, and it also helps us develop content for future sessions that maybe better meets your needs. We're very interested in that. And also, we have another QR code for the next session that I already mentioned on the 12th. I know we're out of time, but I'm happy to stay a few minutes if you have questions or you want to make comments. And I want to just say thank you for joining us. I know how important your time is and how stretched you are. And this is such an important topic that I really appreciate that you took some time to spend with us. I also have some references here, and I'm happy to share slides if people would like more information. So I'm going to stop sharing so we can see each other a little better. If you have any comments or questions, we're happy to take a couple minutes to do that.
Thank you. Thank you so much. This was a fabulous presentation. So thank you so much, Dr. Terrell and Jamie Woods, Dr. Jamie Woods. And yes, please do see the links in the chat, register, as well as it's very important for us to have that evaluation and continue our initiative with the SAMHSA grant and the curriculum. And I want to say thank you. I think this was really comprehensive and very helpful and applicable.
Great.
So thank you.
We hope you enjoyed getting it as much as Dr. Tyrrell and I enjoyed giving it.
And I was really struck listening because we've gone over the slides together, but listening to Dr. Woods do her presentation on how applicable a lot of that was to exactly the kinds of things that I was talking about too. And how, again, the question came up about generalizability. And so you saw me putting things in the chat during that. It's like, yeah, it's the same thing when you're calling on people in the learning environment. Don't assume. Don't say, oh, the woman in the second row. Say the person in the red sweater. Don't make assumptions like that.
Yeah.
So that's an important tip for the learning environment as well, and how much connection there was there. I really noticed that, hearing you talk about it.
Yeah.
If there are any questions? Going once? Going twice? Otherwise, again, thank you, Dr. Fortuna, for inviting us to do these sessions. And thank you, everyone, for attending. And I hope to see you at the next one. Good night.
Good night, everyone.